Hi, I'm Secretary of Health Melissa Makestead. This video is required by law to provide you information about recent changes to South Dakota laws. South Dakota law does prevent induced abortions when the sole intent is to end the life of the unborn child of a woman known to be pregnant, except when necessary to preserve the life of a pregnant female. South Dakota law defines abortion as the intentional termination of the life of a human being in the uterus. The law prevents any person who administers to any pregnant female or prescribes or procures for any pregnant female any medicine, drug, or substance, or uses or employs any instrument or other means with intent thereby to procure an abortion, unless there is appropriate and reasonable medical judgment that performance of an abortion is necessary to preserve the life of the pregnant female. A couple of important things to point out about this law. Intent plays a crucial role. The law prevents interventions when the sole intent is to terminate the life of a human being in the uterus. However, the law allows for interventions when needed to preserve the mother's life. When a miscarriage occurs, when a pregnancy is located outside the uterine cavity, commonly known as ectopic pregnancy, or when a fetus never formed, the treatment for these conditions are not considered to be an abortion. Physicians should not hesitate to assess a patient experiencing a miscarriage and perform the most clinically appropriate procedure to treat her. South Dakota law does not apply to treatment of ectopic pregnancy. Physicians in South Dakota should evaluate and treat a woman with an ectopic pregnancy as they always have. South Dakota law does not require a woman be critically ill or actively dying for a needed medical intervention to end the pregnancy. South Dakota law permits appropriate and reasonable medical judgment, giving physicians flexibility to make decisions as long as the physician documents his or her thought processes in making their decision. If a life-threatening complication occurs beyond the point of fetal viability, there is no question as to management. The baby is delivered and both mom and baby are given appropriate care. More rarely, such complications occur prior to fetal viability, but a maternal-fetal separation is still legal in these circumstances, even when the foreseen but unintended consequence is a fetal or neonatal death. What follows is a non-exhaustive list of conditions that could necessitate ending a pregnancy pre-viability, including the following: the presence of active hemorrhage into the peritoneal cavity, pelvic organs, or through the cervical canal associated with the maternal hemoglobin of less than 9 grams per deciliter, hematocrit less than 27, or profuse bleeding. Intrauterine infection as defined by 2 or more signs including maternal fever greater than 100.4 degrees, uterine tenderness, persistent maternal heart rate greater than 100, persistent fetal heart rate greater than 160, or foul-smelling discharge through the cervical ostium. Premature rupture of membranes prior to 24 weeks of gestational age, severe hyperemesis gravidarum, as evidenced by 3 or more hospital stays for dehydration and hypokalemia, that is blood potassium levels of less than 3 milliequivalents per liter, that is unresolved by multiple medication therapy. Cardiovascular collapse associated with obstetric conditions such as amniotic fluid embolus or non-obstetric conditions. Preeclampsia with severe features including HELLP syndrome or mirror syndrome occurring prior to 24 weeks gestational age. Acute fatty liver pregnancy, partial molar pregnancy, hemolytic uremic syndrome or thrombotic thrombocytopenia purpura. Chronic or acute kidney disease with serum creatinine level of 1.4 or greater, prior or planned solid organ transplant, current maternal malignancy, poorly controlled autoimmune disease such as catastrophic antiphospholipid syndrome, scleroderma renal crisis, or severe lupus nephritis, or substantial cardiovascular disease as defined by WHO Class 3 and 4. Most of these diseases and conditions are very rare and rarely take place at a pre-viable gestational age with the living fetus. However, you, as a physician taking care of the patient, will still need to utilize your appropriate and reasonable medical judgment. We are not saying that ending a pregnancy would be absolutely necessary in every one of these situations. Base your determination on the patient's clinical status in these circumstances. An intervention to end the pregnancy could be legal under South Dakota law. The key for a physician to ensure they are practicing within the bounds of the law is to document their decision-making process and how that led to their recommended course of treatment. South Dakota law's reliance on reasonable medical judgment is a well-established legal principle in medical practice. Reasonable medical judgment is referenced in statute governing the determination of mental competence, end-of-life questions, determination under the American Disabilities Act, and more. Physicians must notify their patient when they determine intervention to end the pregnancy is necessary due to a life-threatening condition. The law states that the physician should, before proceeding, if possible, inform the patient of the medical indications supporting the judgment that an abortion is necessary to avert the death, that a delay will create serious risk to substantial and irreversible impairment of a major bodily function. This notice does not allow the physician to administer an abortion in the state. Be sure you thoroughly document your clinical assessment. Also be sure that you document your consent process with the patient. Be sure to indicate that the maternal fetal separation is necessary to save the life of the maternal patient. Use your extensive training and education to provide your patients excellent health care. We are confident that you as a physician are well equipped to give your patients the care that they deserve.